name is Joy Hoskins. I'm the Chief Nursing Officer for the department. We have a packed agenda for today, so we've got a lot of information to share. If you have colleagues or other nursing staff or leadership who are unable to join us today, please know that this ITV will be available hopefully within the next day or two via archived webcast, so we can have a quick turnaround to get timely information out to our local health department partners. First on the agenda is Dr. Rob Brawley. He is the Chief of the Infectious Disease Branch within our Division of Epidemiology and Health Planning. Dr. Brawley is a wealth and a wonderful resource for us here in DPH as well as across the state regarding infectious diseases. And he has information about invasive meningococcal diseases to share with us today. That is our nursing CE for 1.2 nursing CE credits. And he'll also provide some information, latest and updated information about Zika. So with that, Dr. Brawley, thank you so much for joining us today. Switch places with you. Everything's all ready to go for you.
Okay, good morning, everyone. We're in a different setting today, so I hope the camera angle and everything works okay. It's being filmed. One of the first things I wanted to start with was not immediately to focus on invasive meningococcal disease, but to talk about Zika virus. I think we may be one of the first states in the union that has now made Zika virus a reportable disease. The department sent an emergency amendment to the reportable disease surveillance regulation to the governor. He signed that emergency amendment, and it was filed yesterday with the LRC, and emergency amendments are effective the date that they are filed with the LRC. So as of yesterday, Zika virus disease became reportable in the Commonwealth. We also are going through the process of a routine amendment to the regulation that has to be done simultaneously with filing an emergency amendment. And so there will be the usual time for comment, and we will let people know more when that time is available. And we also plan to add some additional diseases. There's also a couple of diseases that are being considered next week at CSTE that would be new for national reporting, and we may take advantage of our knowledge of that and add those to the Kentucky reportable disease list. But it will take a while for the emergency amendment to be posted online, and we will notify people when the change is available for viewing and downloading printed. I don't think I'm doing that, but but let's move on to invasive meningococcal disease. So if we continue to hear the sound effects, we may pause and see if we can determine where they're coming from.
Yeah, could everybody make sure that they got their mics muted, please?
So the objectives today are five. We're going to quickly talk about the epidemiology and risk factors of invasive meningococcal disease. We're going to describe the public health investigation and response if you are notified of a case in your county. We will discuss the recommended post-exposure prophylaxis for high-risk close contacts. And for this disease, we recommend post-exposure prophylaxis whether the disease is classified as suspected, probable, or confirmed, and we will further describe those classifications for you. We also will discuss some new recommendations, or newer, they've been around for 3 or 4 years, for PEP for meningococcal disease where the organism is isolated from 2 non-sterile sites, and that's conjunctivitis and pneumonia. There now are 6 FDA-approved vaccines for meningococcal disease. They have different recommendations, and we will discuss those briefly. I'm having a bit of trouble advancing here. There we go. So, again, new devices, new keyboards, so I apologize for the glitch. Invasive meningococcal disease is caused by the bacteria Neisseria meningitidis. It's a gram-negative Diplococcus on gram stain. It has that pinkish appearance on gram stain that you see at the bottom. The organisms are sort of shoved together in the middle and flattened. Worldwide, of the 13 serogroups, about 5 cause the most disease. I've underlined the ACYW135 because they are grouped together in the quadrivalent vaccine. And we also have now a new vaccine or 2 new vaccines for serogroup B. The incubation period for this disease is rather short. It can be as short as 1 day after an exposure up to about 10 days, but it's usually less than 14 days. Humans are the only known natural hosts. It causes severe and acute disease, primarily meningitis and sepsis. It can cause focal infections such as joint infections. In Africa, for many years, there's been a sub-Saharan belt of countries sort of parallel to the equator that have had disease every year by serogroup A. There have been recent efforts.
Excuse me, Dr. Crowley. Whoever just joined the ITV, would you mind to mute your mic, please? Your mic is open.
Yeah, we hear some thundering and pumping noises.
Thank you. Sorry.
Thank you. So we've had vaccines for meningococcal disease since 1978 when the polysaccharide vaccine was first licensed, and the first conjugate vaccines were licensed in 2005. This is spread person to person by respiratory droplets or by the direct contact with nasopharyngeal secretions. I say this, that it is a swap spit disease. So when you have contact with nasopharyngeal secretions with a person who is infected with this organism, you may be at risk for the disease. It is generally not that communicable compared to something like measles as an example, and we'll describe that in a minute. This is one of my favorite photographs. It shows the potential for the droplet spread of both bacteria and viruses. We've often thought that droplet spread was about 3 feet. So a tall person like me, put your arm out, that's about 3 feet. But you can see clearly that this guy is blowing out way more than 3 feet. So it can be 6 feet, it can be 10 feet. It really depends upon the vigor at which someone coughs, sneezes these particles at you. But it's large droplet particles that can spread Neisseria meningitidis. And so simply being in the coughing zone or the sneezing zone, you can be directly inoculated. Your eyes, your nose, your mouth can be directly inoculated, and you could certainly be exposed. If you look at the parallel lines where I've put in a marker for the rate of 1 per 100,000. You can see that there's a huge increase in rate in young children, and the younger they are, the greater the rate, so that infants are, and have been for years, the highest risk group. The little inset shows that in spite of it not showing up well in the larger view, the little inset shows that there also is a fairly sizable a doubling and more in the adolescent and early adult age group. So this is the high school, college age group in our populations that are at increased risk, and we'll discuss that further. I'll skip over this slide, but it's just superimposed showing the percentage of the population that have disease combined with the previous graph. The distribution of cases by serogroup varies by age, location, not only within the U.S., but internationally where you are, as well as time. But in the last couple of decades, we have primarily seen disease caused by serogroups B, C, and Y. And traditionally, we've had the ACYW135 vaccine, so we had a vaccine option to prevent disease for many years, since 1978, for those groups. And about 75% of the cases in teens and young adults are caused by those ACYW135 groups, or at least the CYW135, in the quadrivalent vaccine. And so the vaccines that we've been recommending now for several years very adequately cover that. Well, there's also serogroup B, and traditionally we've had somewhere around 50 to 60% of infant cases caused by serogroup B. We now have 2 vaccine options to prevent that. We'll talk about outbreaks in a minute, but serogroup B also has recently been associated with outbreaks in the U.S. Well, who's at risk? And there really are a couple of major categories of risk factors, and they're host factors and exposure factors. And the host factors really are people that have some sort of immune defect in their complement pathway. And as you can see, this provides a 10,000-fold increase in risk compared to people that have normal complement pathways. If you do not have a spleen, whether you have functional asplenia because you have sickle cell disease, or you have had your spleen removed because of trauma or other reasons, then you're at increased risk for not only this organism causing disease, but other capsular bacteria. The exposure factors are many, but it's crowding. So we see this in households. We see it in college dormitories. We see other factors, such as if you're a clinical microbiologist and you're routinely processing respiratory cultures, then you're at risk of being exposed to this organism. Smokers, and then you combine smokers with some of the other things. So smoking in a bar in previous years frequented by college students gave those students increased risk. These are old data, but it shows that the top of the slide that's not in the blue font shows that the baseline rate is about 1.4 per 100,000 population for Americans in the 18 to 23-year-old age group. You take someone that age group and send them off to college, then their risk of invasive meningococcal disease goes up by 1/3. Well, you also put them in the dorm, and the milieu that happens in college dormitories, then the rate goes up by over 250%. This is an organism that colonizes the nasopharynx. People can be chronic carriers of this organism to the point that it's part of the normal flora when it's cultured, throat cultures as an example. This organism can be part of the normal flora. As I said earlier, the infectious period is 7 days before onset of symptoms to 1 day following the beginning of effective antibiotic therapy. So hospitalized patients are put in respiratory isolation, and 1 day after treatment has been started, they can be removed from isolation. For meningeal disease, this is acute onset of the triad of fever, headache, stiff neck. It can be rapidly progressive. I have personally seen a case where the mom awakened around 7 in the morning. Her baby had fever. She dashed off to Children's Hospital in Columbus, Ohio, where I was a resident in the emergency department. And as she came through the door about 20 minutes later, her baby was falling into septic shock, and that child died in the ER in spite of everything that we tried. And the rash that that child developed, I'll show you in just a minute. But this is an interesting disease also in that if you have meningococcemia without meningitis, you have a bloodstream infection, your risk of dying is actually greater than if you have meningitis and a positive blood culture. So you don't mount an immune response if you only have a positive blood culture, and you can actually have large quantities of organisms causing bacteremia. We occasionally see children who were seen in the emergency room. Doctors in recent years have often gotten blood counts, and maybe the child looks a little bit ill, and they will wind up giving an injection of an antibiotic, or sometimes just send them home with observation. The next day the lab calls and says Neisseria meningitidis is growing in blood culture. ER calls back the parents, and they say, well, the baby's well. They're running around doing fine. And so there are occasional children that have bacteremia without sepsis. They recover spontaneously, and it's one of the unusual features of how this organism affects humans. These are older data, but it shows that about half of the disease is caused, or meningitis is about half of the clinical manifestations. Meningococcemia is a bloodstream infection. It may occur with and without meningitis. It occurs with fever, the rapid development of petechiae, which looks like red pepper sprinkled on your skin, and then rapidly it will convert into bruising, and you can even have a vasculitis so severe that you can lose the tips of your fingers, you can lose your foot, you can lose your hand. Anything where you have terminal arterioles is subject to severe harm, and it can be rapidly progressive. This is the rash of invasive meningococcal disease that is purpura fulminans, it is called. And so you can see that this child has bruising on the face, the extremities, the chest, and pretty much all over the body you see this. It started off with the petechiae, which is just on a child like this, white skin with little red specks that are developing but rapidly changing. Here's an example of the damage that's so severe that on the bottom picture, the toes of this individual probably are not going to be able to be saved. We diagnose disease caused by this bacteria by the isolation of the organism, or we can detect the organism using other laboratory methods such as PCR technology. You can culture from the spinal fluid in the case of meningitis, from the blood, or you can actually inject a little bit of non-bacteriostatic saline into the leading edge of one of those lesions I showed you, draw back, and you can gram stain and also culture that and often isolate the organism. I won't go over the medical management in detail except to say that you have to sometimes treat the intracranial pressure in severe cases of meningitis, and you start off the treatment of meningitis with a broad spectrum combination of antibiotics to cover all the potential pathogens. And then once you isolate Neisseria meningitidis, you can narrow the combination to usually one drug. The CDC CSTE case definition for this disease was revised in 2015. I put here just for some further description the case definition from 2005. It was removed in 2010, but it shows you that it commonly manifests as meningitis or meningococcemia that progresses rapidly from being normal. You can go to bed being totally normal, and you can wake up during the night and the next day, and you have these severe manifestations and shock and death. The new definition is that you have that rash that I showed you, clinical purpura fulminans, in the absence of a positive blood culture. There are other diseases that cause purpura fulminans, but the most common one is Neisseria meningitidis. So we now, for this disease, and we don't have them for every disease, but for this particular disease, we have suspected, probable, and confirmed classifications. And so a suspected case is you have that horrible-looking rash, no positive blood culture, or you have a gram-negative diplococci seen from some usually sterile body site. So you have lots of cells in spinal fluid, doctor sends it off to the lab for gram stain, and you have gram-negative diplococci, then that's a suspected case of this organism, and we would recommend PEP for the high-risk close contacts of someone with only those lab manifestations. Probable is that we have used a laboratory test to identify the antigen associated with this bacteria, or we find it in tissue. Latex agglutination is a test that has been used in prior years. It is being replaced by the PCR test, and so if you have a positive PCR, that is adequate evidence for a confirmed case of Neisseria meningitidis, or you isolate the bacteria from a normally sterile body site, or you isolate the bacteria from one of these lesions that we showed earlier. One of the reasons I wanted to present this again, and we present this lecture in the Epi Rapid Response Team training, but I know there's a lot of turnover in health departments and changes in management, and I think it's important to go over this again, that if you have a report of this organism from a hospital in your county, or for a person who lives in your county, please consider that this is a public health emergency for you to take action the minute you get the report. You need to first go talk to your director, go talk to your nurse leader. If you have a full day in clinic doing other things, you need to ask them, please cancel my clinic. I have other more urgent duties. I hope they will say yes, because this is one of the things that the work you do on this case may be one of the real times that you can directly impact someone and potentially save a life by the work that you do in the next several days. As you'll see in further slides, there's a limited timeline for action to be taken to find high-risk close contacts and recommend that they get post-exposure prophylaxis, and for them to actually receive that for it to be effective. And that's 14 days. So ideally, if you have a case identified in a hospitalized patient, we would like the PEP to be given within 24 hours. And the reason for that, in households or any of the other people that have the high-risk conditions, you can get a case to develop within 24 hours. Household contacts have a 500 to 1,200-fold increase in risk above the general population. The risk is greatest in the first week. As we'll see, the risk, the first week is a very important event. I last night sent out a Excel spreadsheet to the mail groups that got the announcement about today's conference. And I put this Excel spreadsheet together so that it would enable all of us, regional epidemiologists, those of us here at DPH, and local health department nurses and other members of your Epi Rapid Response Team, to rapidly calculate the timeline that you need to be considering for post-exposure prophylaxis. And I put today's date on it so that we could just say, hey, later today after this talk, one of y'all gets a call that this organism is in your county. What do you do? Well, if you just enter the date in that cell that is in yellow, all the other dates are protected, password protected, they auto-calculate, and you have 14 days after exposure. And the way this works is that the column to the right of the colored cell, we have days 0, 1, 2, 3, 4, 5, 6, and 7. So we go back 7 days after onset of disease and find all of the people who are high-risk contacts. And then this is personalized post-exposure prophylaxis. Every person you find has a unique timeline different from their neighbor, their cousin, or other people that were exposed. So it depends on which day you were exposed. So as an example, you could have a case in a daycare, and it could be a child in the daycare that was only there 7 days before onset, and they weren't there other days, so they had only 1 day of exposure. But why it's important to consider day 7 in the first week is that we go back 7 days, but we then go forward 14 days. So the person who on day 7 before onset, we've already used up the first week by the child that really had the disease having no symptoms for a week before or a week after the exposure. So someone that was exposed on day 7 before onset, you had 14 days, but you only have 7 remaining days. And so it becomes then more urgent to find the people that were more remotely exposed than the people that were exposed the day of onset of illness. And so this simply calculates the last date for administering post-exposure prophylaxis. And so if the onset was today, someone that was exposed on day 7 before onset, we have until the 23rd of June to find that person. Well, what happens if they're out of town and we don't find them quickly and we find them on June 26th? We don't recommend post-exposure prophylaxis. We recommend education at that point. There's no evidence that post-exposure prophylaxis administered beyond 14 days is efficacious in preventing disease. And so we recommend education about the signs and symptoms of acute meningitis and sepsis, and ask them to seek urgent care if those develop. But the risk will wane fairly dramatically after the 14th day. So who's high risk? You go and ask people, who is the index case been around? What have they been doing? What have been the relationships and the associations? And we find that anybody that lives in the household with an index case is automatically classified as high risk, especially if the people that live in the home are children younger than 2. They certainly are high risk. Anyone that has had sleeping arrangements with the index case or slept in the same dwelling. So this is where some of the contacts in college become important to find out who's been sleeping with whom if they have a known case of invasive meningococcal disease. In terms of the swapping spit comment, anyone that has direct contact with the nose or mouth and the oral, those secretions of the index case. You kissed the person on the mouth. You shared cigarettes with them. You shared lipstick with them. You shared lip balm. You ate after them. Here, take a bite of my pizza. If you did that and they have this disease, you're a high-risk contact. You drank after them. And so in the college setting, in a bar, everybody's got a pitcher, and they're swapping, and have a taste of my beer, I'll taste yours. It's easy to see how you could have a lot of high-risk contacts. We often have a lot of healthcare workers that are concerned that they're high risk, but only a few healthcare workers are high risk if there's a case of this disease. And it's the people that have intensive unprotected, meaning no mask, no shield, facial shield, and you're doing care with the infected person. So you're doing mouth-to-mouth resuscitation. You're doing intubation. You're doing suctioning. And if you're not wearing the PPE that you should be for doing those tasks, then you may be exposed. If you're closely examining the nasopharynx and the individual coughs and sneezes right in your face, then certainly you're a high-risk contact. If you have a case of this disease develop in a daycare, nursery school, preschool, then everybody, staff and children in that facility, are high risk and should be given PEP. Now, the comment earlier that it's infectious, but it's not as infectious as earlier, or as other diseases, is relevant in air travel. And the comment is that if you are on an airplane and a passenger on that plane develops this disease, you have to be sitting immediately next to the person, and the flight duration has to be at least 8 hours. And so we're talking international flights from Africa, Asia to the U.S. We're not talking from here to Chicago. We actually have had this occur in Kentucky. We had this occur one year, and we found the individual and gave PEP, but it does require this time duration for the exposure to be high risk. Well, who's not high risk? And again, you will determine who has been in contact with the index case, and then you need to classify them into high-risk contacts and low-risk contacts. And so the low-risk contacts are the casual contacts at school and work. So let's say you're in college, you're in one of those large freshman lectures in an auditorium of 500 people, and you're across the room and somebody says, well, that person over there had this disease. You're not a contact. Unless it is later identified that you had other relationships with the index case so that you would be a high-risk contact. You may have been in the classroom, weren't sitting next to them, but they were in your fraternity or sorority, and the day before they were admitted, you were swapping drinks with them at a local bar. Then you would be high risk. In infectious disease, if you are a contact to a case where PEP is recommended, but you've never actually been a contact to the real patient with illness, you're not a contact to the disease. And so we call this an indirect contact. You know the parent, let's say, they work with you. Their child is admitted to the hospital with this disease. They work with you, but you haven't been around their ill child or been around their child at all. You're not a contact to the disease, and PEP would not be recommended. If you're a healthcare worker that was simply in the emergency room, but you had no direct contact with the care of the patient, you're not a contact to the patient either. But we often have hospital emergency departments that everybody who is able to be in the same department the time the patient was there wants PEP. I often will ask the infection preventionist to go do an in-service with the emergency department when the use of PEP has been excessive. It's only a single pill, as we'll see, of Cipro as an option. And people think, well, just one pill, what the heck? Well, one pill, if you're allergic, can cause anaphylaxis and potential death if you really were not someone that should have gotten it at all. So we need to be judicious in our use of PEP. Well, why don't we just go and draw my blood? I've had the vaccine. Surely you can draw my blood. I don't need that antibiotic. And the answer is we don't do it that way. There is no known level of immunity, even if you've received this vaccine. There's no known level of immunity that we can guarantee will protect you. So we recommend post-exposure prophylaxis for all high-risk contacts, regardless of their immunization status with one of the vaccines that can be used for meningococcal disease, as long as the PEP can be given by day 14. So there are several different antibiotics that can be used. Rifampin is one. Cipro is the common one. It's the single dose. Ceftriaxone is a medication that can be given by injection for children under 15 and for pregnant women. The one admonition about rifampin is that it alters birth control pill cycles. So if a woman is taking the pill and receives rifampin, then other methods of birth control need to be used for the remainder of that cycle. It also causes body secretions to turn bright orange. And if you wear soft contact lenses, it actually can permanently stain those contact lenses. And so that needs to be part of the counseling. But rifampin isn't used that often. Some people also get a flu-like syndrome if they take rifampin for PEP. They'll get myalgias, arthralgias, but that's temporary, but it has been shown. Well, do we also give meningococcal vaccine along with PEP? And in the United States, the answer currently is no, we do not. But if there is an outbreak, as long as the outbreak is caused by a strain of the bacteria that has a vaccine that can be used to prevent those cases, then in the U.S., the use of vaccine can be an adjunct to the antibiotic chemoprophylaxis. The recommendations in Canada are different and have been for several years. You go back and see that the guidance from Canada was from 2005. So for more than a decade, the Canadians have been using meningococcal vaccine as an adjunct to the use of antibiotics, even for a single case. So there now are 6 different vaccines for meningococcal disease approved by FDA. We'll first mention the serogroup B vaccines. There are 2 different ones. And the use of serogroup B vaccines for this disease is evolving.
You do. You need the remote, but they're on top.
So someone needs to mute their phone if you've just recently joined us. Thank you so much. There's a difference in the number of doses of serogroup B vaccine by the 2 products that are currently recommended. This one from GSK is 2 doses, at least a month apart. It is routinely recommended for use in children starting at age 10 through age 18. And for adults 19 and older who have any of those high-risk conditions that would make them at risk to invasive meningococcal disease by this serogroup. The competitor made by Pfizer and Wyeth presently is recommended by ACIP as a 3-dose schedule. This was recently FDA has recently changed the licensure so that there is actually a 2-dose schedule for this product. It has not yet been recommended by ACIP, so they meet this month, and so that may change, but I haven't changed the slides. The major difference is that you cannot interchange these vaccines. For certain vaccines like hepatitis A and hepatitis B, doesn't matter which brand of the vaccine that you use, but currently for the serogroup Bs, you have to stay with the product you start with. There also is a vaccine that includes the serogroup C and Y and Hib. It's called Menhibrix. You can start using that vaccine as early as age 2 months. The quadrivalent vaccines that have been around for a while, the brands are Menveo and Menactra. They're the ones that are usually given for the adolescent doses. And then the original quadrivalent vaccine, the polysaccharide vaccine, is still in the marketplace, but it's rarely used. And ACIP currently recommends that its use be limited to persons who are aged 56 years and older. Well, we've had outbreaks occasionally in the United States. They have been increasing since 1991. They usually have been caused by serogroups C and Y, and B was occasionally reported, but starting in 2009, and this was through 2013, there were multiple college campuses that had outbreaks of serogroup B, to the point that CDC actually brought in from out of the country the serogroup B meningococcal vaccine as an investigational new drug, gave it on college campuses, showed that it was effective, and that led to the actual marketing in the United States. So if you have the outbreak being caused by a serogroup B, then you can use those for children that are 10 through 18 and adults that are 19 and older. You can also use the brand that can be given down to starting as early as 6 weeks if it's caused by serogroup C or serogroup Y, but not a serogroup B. And if it's caused by any of the serogroups in the quadrivalent vaccine, then those two vaccines can be used, but preferably the conjugate vaccine would be used. There are some public health definitions of what constitutes a meningococcal outbreak, and it's usually 3 or more confirmed or probable cases in a short period of time, 3 months or less, and there are some thresholds for the use of vaccine, and it depends upon the size of the population. So for small populations, just 2 cases. For larger populations, 5,000 and larger, 3 cases in the population. We have occasionally, I've been here going on almost ready to finish my 11th year, but we've occasionally gotten calls about having a positive culture of this bacteria from the conjunctiva or from sputum, and what do we do? So we considered this a few years ago, looked at the literature, and we decided to change our recommendations and recommend post-exposure prophylaxis for meningococcal conjunctivitis and for meningococcal pneumonia, but we have some specific case definitions that we want you to use when considering PEP. The reason we've recommended PEP is that even from these diseases, you can have transmission and secondary cases in high-risk close contacts. This is different from the CDC recommendations. So if you look at the Red Book, the Academy of Pediatrics and the CDC have no definitive guidelines concerning PEP for either of these diseases, but we at the Kentucky Department for Public Health do recommend it. And so the following case definitions are things that we want you to consider, and that is if you have a report that you have Neisseria meningitidis isolated from a culture of the eye or the conjunctival sac associated with purulent conjunctivitis, then we would recommend PEP in the family members and other high-risk contacts of that case. Well, what about pneumonia? Well, this becomes a little more difficult because there are multiple criteria. We want actually clinical and or radiographic evidence of pneumonia, and we want laboratory confirmation of the infection. And what we mean by that is that we would like to see a sputum specimen submitted to the laboratory, gram-negative diplococci on the gram stain, and also the laboratorians can determine if that specimen is actually sputum, meaning lower respiratory, or is it saliva. If it's saliva, you will have a lot of respiratory epithelium, that oral epithelium, and so, but if you instead have white cells that you're seeing in addition to the positive gram stain, then that is supportive of pneumonia. And then we would like the laboratory to report that they have a heavy growth of this organism, because it can be part of the normal flora. If it's causing pneumonia, it should be heavy growth either in sputum or in the tracheal aspirate specimen. The vaccines are routinely recommended for all children now in the United States, routinely starting at age 11 or 12. There's also a booster dose for adolescents at age 16. And there's no booster dose recommended if the first dose is given, say, at age 18. It's also recommended for some high-risk people. If you're going to college, going to live in the dormitory, then you should get it. If you're going to have international travel. You have no spleen. That's the last bullet. People 19 to 55 increased risk of invasive disease. Then they need 2 doses. So it's also routinely recommended for people that are 2 months and older, depending on the vaccine chosen will certainly have to be considered depending on age. If you have one of those complement deficiencies, or if you're taking a particular drug for a treatment of a disease, if you have no spleen, you work in a micro lab, you're working with this organism, you're going to travel to a country where this disease is endemic or hyper-endemic. So it's really any international travel. I recommend that people get meningococcal vaccine. And the more remote your experience is going to be, then the higher the risk that you need to get this vaccine. So you don't want to be backpacking in Thailand and come down with invasive meningococcal disease, because you probably would not survive. It's given routinely to military recruits, and as I said, college freshmen living in dorms are routinely recommended to get it. The one vaccine is only for infants and toddlers, and then the quadrivalent vaccine is routinely recommended for children aged 2 through 55 years, and adults through 55 years of age. If you're older than 55, you can give the polysaccharide vaccine, or you could use the quadrivalent vaccine if the polysaccharide was not, you could use the MCV4 if the other vaccine is unavailable. The recommendations for serogroup B vaccine, as I said, are evolving. It is now routinely recommended along with the quadrivalent vaccine for children aged 10 through 18, and routinely recommended for adults, regardless of age, starting at age 19 and older, if they have increased risk that could be caused by serogroup B. Well, what about if you're going to college? Is serogroup B recommended? And what ACIP has said is that this is really now not a routinely recommended vaccine. It's one that which the parent, the student that is going to college, and the provider need to have a discussion about whether this vaccine is needed. But adults 16 through 23, with the preference to get it at the same time they're getting the booster dose of the quadrivalent vaccine, they may be vaccinated with the serogroup B vaccine to provide short-term protection while they're going to college. But the 2 serogroup B vaccines are not interchangeable. So you have to give the same vaccine for all of the doses that are recommended. Would I recommend that college students get this vaccine? Yes, I would. I hope that eventually the ACIP will routinely recommend it for college students, but at this time it's not a routine recommendation. But I know a lot of students are getting it, and the companies that make this vaccine are certainly educating providers about its use. Any questions?
I have a question, Dr. Raleigh. If somebody refuses to do the PEP, is there any ramifications for that at all?
So the question was, you identify a high-risk close contact, and they are recommended to get PEP, and they refuse. What do you do? Well, I think you would first document that carefully in your medical record and your public health record. But you should then educate them about the signs and symptoms of the disease and ask them to seek urgent medical care if it develops. The one thing is that by the time it develops, if it happens to be somebody that has no spleen, as an example, by the time they get to the hospital, the die may be cast for fatal disease. So they really need to understand that this can be rapidly progressive. You can go from well, being at work, to dead within 1 day. And so they really need to understand that the PEP can be life-saving. questions from the field or anyone else?
So in case of an outbreak, is vaccination recommended for people who already have vaccination?
The question was, in the case of an outbreak, would vaccine be recommended? And it would depend on the serogroup. So as an example, if you had people vaccinated with the quadrivalent vaccine and it was a college campus, it was serogroup B, then certainly regardless of the prior status. I'm not aware that anyone is recommending a booster dose for those, if it was serogroup Y as an example, if people have been boosted. But if you have ongoing risk, if you're an international traveler, you're always going on mission trips to Africa, let's say, where it is endemic, then every 5 years you should get a booster dose. And so I think we might consider, if it had been more than 5 years since someone had had the quadrivalent, that they would get a booster dose. Yes?
Students who live in the dorms and PEP, which students would get in the dorms? Would it be all the students in the dorm or certain floors?
The question was, you're at a college campus on some city in UK with a college. There's a case in a student who lives in the dorm. Who else in the dorm gets PEP? The question was, is it everybody on that floor? Is it the whole dorm? And the answer is you really should you should identify, and this becomes a challenge in college because of the rapidity at which people are moving around and some of the relationships, but you should try to identify the high-risk close contacts. And so certainly the suite mates, the roommates of the person would be high risk. Anyone that had a relationship that involved the sharing of secretions, the sharing of food, you would try to identify them. But we would not normally recommend a whole dorm or a whole floor. It might be, you'd have to individualize it, because some of the floors, everybody goes to the same location to use the microwave. And if they had a pizza parlor, and everybody was sharing food, you might end up having the whole floor. It would just depend. But I think you would individualize it. There was a case recently that was in the MMWR. They called it expanded chemoprophylaxis. There was a school where the person who had the acute disease also had a cough, and they somehow identified that this person had coughed in the face of multiple other students, and so they recommended a chemoprophylaxis for a group beyond the normal high-risk group, and they published that in MMWR, so we may encounter that too.
So you were talking about airplanes, so you would not recommend like sitting in front of somebody that had, like, you're on the airplane and, they coughed in front of you and parted your hair. This happened to my husband. The person coughed from behind and parted his hair.
Wow.
And, it was a short flight, but, we're like, okay, well, I hope he didn't have pertussis or TB or anything like that.
So the question is, okay, somebody's on the airplane and they're sitting in front of someone and they've got a cough and they're coughing so vigorously that you can actually feel your hair move as parted your hair, as the comment was. What we can do is to cite what CDC recommends in that case, but what happens then when a person goes to their own provider, that provider has to make a decision. It is spread by respiratory secretions, but the back of your head is not a place that normally gets further exposure. Now, if you wiped your hair and you got a big glob of secretions and you somehow later touched your eye, touched your nose, then that's a different story. But the admonition about chemoprophylaxis is the person sitting across the aisle is not a contact. But if you're sitting directly, you're in the middle seat and they're on either side of you, then you're exposed if it's a 9-hour flight. Other questions? One last comment about Zika is that we have sent out to all the different mail groups a notice about the disease now being reportable. Joy Hoskins also further sent that to her mail groups. So people hearing the call today, if you did not get a notification either last night or today, then you're not on a mail group you need to be on. And so would you contact me or Joy or Sandy Kelly, and we'll add you to the relevant mail group. So thanks, everyone.
Thank you, Dr. Brawley. Thank you, Dr. Brawley. As a part of that Zika announcement, you also attached the revised EPID 200 as well as the revised list of reportable diseases for Kentucky. So there would be 3 attachments to the email that Dr. Brawley sent out last night or that I forwarded to you this morning. So those documents you'll have for your reference and your information. If you have any questions about those forms, you may contact Dr. Brawley or Shelley Wood. Dr. Brawley, would that be appropriate to either contact either you or Shelley Wood about the Zika forms, or who else would you like to have them contact?
Shelley Wood is our usual contact
Yes,
for
sir.
questions, but
Okay.
You can call the reportable disease section. Sandy Kelly, call me. If folks need help, we want you to call till you get someone and not just leave a voicemail.
Yes. Okay. Thanks again, Dr. Brawley. Next, we have Katie Myatt, who is an epidemiologist in the reportable disease branch. Katie is going to be providing us information about hepatitis C investigations. As you all know, the incidence of acute hepatitis C is on the market increased in Kentucky. Kentucky is number 1 in the nation for acute hepatitis C cases. So this information is quite timely and informational, Katie. So we appreciate your time with us today to provide this information to us.
Good morning, everybody. Pull my PowerPoint up. Oh. You're getting a quick overview. Watch fast. Okay. So I'm going to talk a little bit, like Joy said, about hepatitis C, the epidemiology, investigation, and reporting of hepatitis C. However, I'm going to focus mostly on the 2016 case definition, NEDS entry, and then the 2015 reg change that's going to take effect actually in October. So you have quite a few slides that were sent out yesterday that we won't go over, but they're good reference materials, so I wanted you all to have those too. So to begin, hepatitis is inflammation of the liver. It can be caused by a variety of different things: drugs, alcohol, bacterial and viral infections. In Kentucky, we're usually most concerned with viral hepatitis, hepatitis A, B, and C viruses. There are also hepatitis D and E viruses as well. And as far as reporting, we report acute infection. So acute Hep A, acute Hep B, and acute Hep C, with a couple of exceptions for perinatal cases. So hepatitis C is a single-stranded RNA virus. It replicates in liver cells, and there are about 6 different genotypes with over 50 subtypes. I like pictures. So this is a picture of the hepatitis C virus. You'll see, does my mouse work? Yes. So right here, you've got the single-stranded RNA surrounded by an envelope with little glycoproteins on the outside. You can have asymptomatic infection with hepatitis C. About 70 to 85% of people will develop chronic disease. But I think it's important to keep in mind that, not everybody is going to be symptomatic. Incubation period, 4 to 12 weeks, with a range of 2 to 24 weeks. And it's transmitted primarily through percutaneous exposure to infectious blood. somebody's mic is not muted, if you don't mind to check. So people who are injection drug users, people that received blood products, or organs prior to 1992, a healthcare worker who had a needle stick injury, or a baby born to a mom who's infected with Hep C are at risk. In addition, less frequently, you can get hepatitis C through sex with an infected person, sharing personal items that might be contaminated with infected blood, razors, toothbrushes, and certain healthcare procedures can put you at higher risk, and then tattoos, body piercings, and intranasal cocaine use as well. So this slide just gives you, it goes over transmission again by giving you all the risk factors, just gives you a decent list to look for. I wanted to go over the symptoms just because I think they're important to note with regard to the case definition. Fever, fatigue, dark urine, clay-colored stool, abdominal pain, loss of appetite, nausea, vomiting, joint pain, jaundice. And again, people can be asymptomatic. And the reason I wanted to list there is the case definition, I think now, puts in a list of example symptoms, but prior to this, this revision, the case definition stated any symptom consistent with acute viral hepatitis. And so you had to remember what those symptoms were. So that's why I like this list. And I like this picture because it shows you what jaundice looks like. Again, lots of good reference material for you all to go back to. As Joy stated, our Kentucky rates of acute hepatitis C are much higher than the national average. You'll see that navy blue line down at the bottom that's fairly parallel to the axis. That's the national rate of acute hepatitis C. The one above that is Kentucky's rate of acute hep C. And we do have a jump in 2013. That's likely in line with when we switched over to NEDS from DSM, so our electronic reporting surveillance system changed. We had LabCorp jump on for reporting electronically for labs, and that I don't believe that was an outbreak of any kind, just a reporting change. So if you all get a case of hepatitis C in the local health departments, what do? So we always educate our patients on prevention and guide them. So there is treatment available. That treatment is dependent upon genotype, and in my opinion, from a non-clinical background, it's fairly complicated. So I just, I want to make sure everyone's aware that treatment is available, and our patients need to be referred to providers so that they can be treated appropriately. Educate on minimizing the use of anything that might be toxic to the liver. Educate on how to prevent exposures to any of the contacts that they might have, household contacts, kiddos, sexual partners. And just a point at the bottom, we do test we would recommend testing for sexual partners, but in general, not for household contacts. So, like I said, for kiddos, you want to educate moms if they're breastfeeding on protecting their babies from blood if there's blood there with nipples cracked or bleeding, which can occur. You want to recommend vaccination for hepatitis A and B, and recommend that they don't donate blood, organs, or tissue. So, what is the case definition and what are the changes? This is the link to the National Notifiable Disease Surveillance System website. This is where all of our case definitions are housed, with the exception of histoplasmosis and toxoplasmosis. Those are on NEDS. But and I'll show you this in the NEDS demonstration, there is a link to this website on your homepage from NEDS. So you can either use this and bookmark it in your computer, or you can go straight from your NEDS homepage. So here's the site. Right on the left side, you search for your condition. Pick what you'd like. And here is the acute hepatitis C 2016 case definition. Most of our case definitions have two parts: a clinical criteria and a laboratory criteria, and those parts come together and form the case classifications. It's easier for me to think of it kind of in parts instead of all at once, because I think that hepatitis C has lots of going on, and you have to meet all these different components to be able to say whether or not you have a case. So as far as the clinical criteria, you have acute onset of any sign or symptom consistent with acute viral hepatitis. So here's a short list of symptoms. In addition to acute onset of symptoms, the person also has to be jaundiced or have an ALT of greater than 200. For those of you all that have investigated hepatitis C cases in the past, you'll notice that the ALT level has been reduced. I think the 2012 definition was the last updated, and it required an ALT of 400. So we've broadened our definition a little bit. We should be able to catch more cases that way. As far as the lab criteria, I feel like this got a little bit less confusing. So you have to have a positive test for antibodies to hepatitis C, or hepatitis C virus detection test. So your PCR test, either a quantitative or qualitative PCR or a genotyping. And then if and when the FDA approves hepatitis C antigen testing, that would count towards your laboratory criteria as well. So those are our two parts. You come down here and you'll notice that not only do we have a confirmed case classification, but we also have a probable. That's a difference as well. For the probable, you still need signs and symptoms. You need either jaundice or an ALT of greater than 200. But if you get an antibody lab that just says hepatitis C antibody reactive, that would meet your laboratory criteria and therefore your probable case definition. The signal cutoff ratio that was in the 2012 definition is no longer there, so you don't have to look for the greater than 11 to meet your laboratory criteria. And then in addition to your probable definition or case classification, you want to make sure that that person hasn't had a negative hepatitis C lab in the 12 months prior to the positive lab. For confirmed, your clinical criteria, again, has to meet, and then either your PCR test, quantitative or qualitative, or your antigen test when that becomes available. And then, I think the time period just changed on this part. If you have a patient that has a negative lab for hepatitis C, and then 12 months later a positive lab, they're now a confirmed case. So it used to be 6 months, now it's 12 months. And the great thing about NEDS is that, at least for LabCorp, and starting in October of 2016, you're going to see negative test results for our hepatitis patients. So NEDS will document that for you. You'll be able to see when that comes in, and it should be fairly easy to see whether or not they've converted. So let me go ahead and ask if anybody has questions on the case definition or. Okay. All right. So here's a good list of the changes. The REBA is no longer listed as a diagnostic test. That's not something I really said. In the 2012 definition, if the person was co-infected with hepatitis B, you couldn't be considered a hepatitis C case. So that's no longer a part of the case definition. So again, I feel like it's a little bit more simple to follow than the 2012 definition. So I wanted to go over entering a hepatitis case in NEDS. There are a lot of fields that are required in order to meet the case definition and to get your notification approved. And so I thought it'd be helpful if we could go through some sample labs, go through entering them, and then go through entering an investigation. I think somebody's mic is not muted again, if you don't mind to check your mics. So, you all should have sample labs, I'll go ahead and pull mine up, that look like this in front of you. So we're going to start with this antibody test. This is one that I saw a lot when I was in the local health department. A physician has ordered a hepatitis panel. You get results on hepatitis A, B, and C, and you might have, like this person, one that's positive and the rest are negative. But I think it's useful to see an example like this. All the green highlights are things that will go into your NEDS entry. So your collection date, the ordered test is your hepatitis panel, your resulted test is your hepatitis C antibody, here's your lab report date, your reporting facility. So hold that out in front of you and let me show you how I entered it in NEDS. And I thought I was being really clever when I was creating this case. I called it hepatitis C. I named it right. I was very proud of myself for that. So here is Mrs. Hepatitis C. And let me stop right there and mention I forgot. If you all if you're new to the local health department or new to reportable diseases and haven't seen the NEDS training site, use the link in your PowerPoint. You can go to this training site, make up anybody you want, and practice entering cases. So for reportable disease training, it's a really great tool. Like I did with this, I created a fake patient, and I entered labs and an investigation, and it just gives you some really hands-on experience with using NEDS. So here is the lab report that matches what we were just talking about. We've got the name, home address, home phone number, all the patient demographics. And then here, we've got our actual test results. NEDS wants to be slow today. Okay, here we go. So, for the sake of time, I'm not going to enter each thing, but I can go through and show you everything. So, demographics, jurisdiction, this is a Franklin County resident. Here's the lab report date, which should match what you have highlighted. The date we received it in public health, which if we got that same day lab report, that would be phenomenal, but that's probably not realistic. Ordered test is a hepatitis panel, and here is your actual test result. So I hit search and typed in hepatitis, and that'll give you a list of all the tests that have the name hepatitis in it. You just search through until you find the one that you want, and this was an antibody test. So select it, and that puts it in this resulted test field. The results on the lab report indicate it was reactive, and there's not a great place to put the signal cutoff, and because it's not needed in the case definition anymore, it's not necessary to meet. However, if you have that data available, you really want to put it in NEDS. So I put it as a text result. You hit your update test result, and then you're pretty much done with entering your lab. So hit submit, that's your enter button. And then you wait for NEDS to get done. And there's your final report. So everything you have on here should match the paper lab. Does anybody have any questions about entering a lab?
Can I just say something? Sure. I know that you don't want to enter anything that's negative, but on somebody like a hepatitis panel, especially if it's a woman, it's good to enter that negative hepatitis surface antigen if they're between that the birthing age.
Yeah, okay.
Just because if they're going to be pregnant at any time. It's nice to know that if we're ever searching if she's pregnant at any time.
So that's a good point. The comment that Julie made for, because we track perinatal hepatitis B and C now, it's good to have those negative test results. So if you have a patient that you're investigating for acute hepatitis and you have labs like hepatitis B surface antigen available, go ahead and enter it in NEDS. That way we have a record of it. I think I alluded to it, but probably didn't explain it very well a few minutes ago. The great thing about NEDS is that it's patient-centric, and it's just a medical chart, pretty much, for what we have on these patients. And so if we ever come across Miss Hepatitis C again for purposes of her being pregnant, and we want to see if she's positive for hepatitis B surface antigen to track the baby, we already have it in NEDS, correct? So any other questions or comments?
Katie,
Uh-huh.
this is Karen in Madison County. At one time, we were told in that lab text box to enter the name of the lab who had done that test. Is that still current, or has that changed?
It depends on what the lab report looks like, and how many need to, there you go. It depends on the lab. So if I'm getting a lab report from Quest, and I didn't get, and I got it directly from Quest, I didn't get it from, a provider giving me a lab, then I would put in this field right here, the reporting facility, as Quest, and then everybody knows that Quest reported it and they did the laboratory test. If you received a report from Dr. Smith and they sent the lab result with it, then your reporting facility would be Dr. Smith, and then you would want to put the name of the lab in there. So does that make sense?
I think so.
Okay. It just depends on the report. So you should be receiving reports from providers and reports from laboratories. If the laboratory is the one that's reporting it, then you put the name right here. If they're not the ones reporting it directly, which can be the case, like if your hospital reported it, then they sent the lab out, then you would have to put the name in. Make sense? Vaguely? Okay. Uh-oh. Okay. So if you scroll down on this sheet, so that was our hepatitis antibody test. Here is an example of what the PCR test looks like. The ordered test is a hepatitis C by quantitative PCR, but you'll see on here you have quantitative results and qualitative results. So the green highlight is your quantitative PCR. Those are numbers. Your qualitative PCR is going to say detected or not detected. So, let's see. So we'll just go through this real quick. So here's my NEDS lab. I put in the quantitative results. I put in the twice. So you got a log result and then just copies per mil. And I put those on the same lab because they're on the same paper lab report. So you can put that in the same NEDS entry. Does anybody have any questions about this? Entry is the same.
Me too. Okay. And with Hep C and Hep B, sometimes you need the whole panel to decide whether they're hepatitis B, chronic or acute.
True.
You know,
Very true.
sometimes it's good to have everything in there.
And the great thing about LabCorp and Quest right now is they're already reporting electronically. So you won't have to manually enter labs from those facilities. And we'll talk a little bit more about what's going to happen in October 2016. But hopefully manual entry of lab reports will will be required much less. So, let me move on to the investigation, because this can get kind of tricky. As we discussed, the case definition it has many pieces and parts. In order to meet that case definition, your investigation in NEDS has to depict all of those pieces and parts. And then to complicate it just a little bit more, there are fields in the investigation that are called searchable fields. If those fields are not completed, CDC can't see them and therefore cannot approve the notification. So we're going to go through the different fields in the investigation to show where you have to put your information, where you can't put your information to have it count. So, so again, I just made up some information for this investigation. And we're going to go tab by tab. So here's your patient demographics tab. You've got all your information. Try to be as complete as possible. If you have it, put it down. Try not to leave any blanks. When your regional epidemiologist or your nurse consultant at the Kentucky Department for Public Health looks through these, we don't know if it's blank because it's unknown or it's blank because the patient refused to answer that question. We just don't know. So if you can put in some information in that field, that's better. And of course, you're not going to fill in every field, but just try. What I want to note here is every tab has a comment box. If you put comments about signs and symptoms in the patient demographics comment box, the CDC won't see them. So they can't approve the notification if we put comments here. And I know I had one particular facility when I was at the local level that would send me morbidity reports, and this was her preference for where she put her signs and symptoms. So what I would have to do every time was copy out of this field, paste it into another field, and then go from there. Unfortunately, it just doesn't come across to the people that need to see the information from this tab. So try not to put your comments there. This is the general hepatitis tab. This is where the bulk of your clinical information is going to go. So reporting source, whoever gave you the report, if it's a laboratory or if it's a hospital, provider, whoever. Hospitalization data, and then some specific clinical information. So why did they test the person? Well, for this one, the person had symptoms of acute hepatitis C. Was the patient pregnant? Particularly important for our reporting requirement for perinatal hep B and C now. So you want to make sure you mark that. Was the patient symptomatic? Yes or no? What was the onset date? Was the patient jaundiced? And did the patient die? These are all searchable fields. So make sure you mark those. Even if you write down in the comment box here that the person was symptomatic, you still have to mark yes here. So I know it seems like you're putting the same thing in multiple places, but you do have to write that down so we can confirm your notification. Jaundice, part of your case definition, so you want to mark that. Here is your laboratory information. So if the person had an ALT of greater than 200, you need to put that in this field. It's nice to have the upper limit from the reference range from your lab, so try to get that down. Every lab's range is different. So if you have a case that is borderline elevated, you'll want to know what that reference range was. And again, these lab fields are searchable fields. So you've already entered the lab manually, or you've reviewed it through Quest or LabCorp reporting it. Why do you have to enter it here too? Well, because these are the fields that CDC needs to see. So make sure you're writing down yes, no, or positive, negative, unknown on all the information that you have. So here we had a hepatitis panel. On that first lab report, they were surface antigen negative. They were hepatitis IgM negative. So you can put all that information here as well. Okay? Here's your antibody test. We can mark that as positive because we know the RNA was positive. And we don't know about hepatitis D and E. So we have a PCR positive. We have signs and symptoms of hepatitis. Let's say this person had nausea, vomiting, fever, and a headache. And they were jaundiced. So we meet our confirmed case definition. So we can put that in case status. Oops. And then come down here, put nausea, vomiting, fever, headache. And then if you know of any risk factors, you can put those in. Let's say we'll put IV drug user. Put that in. And then I like to do this, just put my initials in and the date that I made that note. So we have some sort of record for it, okay? Some more symptoms fields. If you had, obviously I had a temperature, so you can put the highest temperature there. Days of diarrhea, 7 days if that's the case. And then once you click that the diagnosis is an acute hep C case, you'll get this acute hepatitis C tab. And this is where all your exposure information is. So when you call the patient, you can ask all these questions, should ask all these questions, write yes, no, or unknown in all the fields. And then when you're finished, hit submit, and you finished your investigation. So does anybody have any questions on Ned's investigations? Or would like to see something else as far as entering cases? Okay, well that went much more smoothly than I thought. So,
hold up, Katie.
Okay.
I have a question. This is
Okay.
Mita from
Hey.
Lexington. Hello.
Hello.
I have a question. What if the patient doesn't meet case definition? And it's not, so you mark not a case. Do you still call the patient and get the acute hepatitis tab filled out?
It doesn't meet acute case definition?
Yeah.
I mean, you're still going to want to do some prevention education, I would think.
Yeah.
So I don't know that I'd skip that tab just because it's not a case. And you might not. That's a good question. You know what?
How do you know?
I mean,
Well,
yeah, I can definitely call them for prevention, but there are cases where the doctor, the provider has actually done a good job of educating the patient and telling them, prevention and interaction with others. Sometimes even a better job than I can offer. So, yeah, I definitely do understand calling for prevention methods, but, I just wondered.
Yeah, should you, make them do a complete interview on exposure when you don't have a case. Let me take that back and send an answer out to the group because I think that would be useful to the group. How about that?
Cool. Thank you.
All right. You're welcome. I'm making a note. Hold on just a second. Okay. All right.
Hi, this is Ava from Madison County.
Uh-huh.
I had a question about the state lab now that we are sending out the hepatitis C testing at the local health departments.
Mm-hmm.
If there is a positive that's confirmed with the quantitative, are they reporting that into NEDS, or how should that process work? Because they're actually performing the test.
Mm-hmm.
No, it's not.
Yeah, it's, yeah. As of right now, it's still an outreach report. So just like your enteric diseases, you'll get the lab report and you'll have to manually enter that. So until that
So
changes.
It's the local health department's, I just wanted to clarify it, that's what we thought, but it's the local health department's responsibility to enter those positive Hep Cs into the, NIDS.
Yes.
Okay, thank you.
Okay. You're welcome. Okay. Any other questions?
Hey, Katie, this is Mary. Can you hear me?
Yes.
Okay. From our outreach side for the EPIs, I cannot see those labs. I've talked to Ken about them. They're going to the clinic setting, which we don't have access to. So the clinic will have to pull those and get those to the people that do the reportable diseases for that county.
Okay.
It's just not something that we can view.
Okay. So, I'm sorry. Local Metro. So their communicable disease department. So I know that's an ongoing issue with reportable disease access and outreach and who gets test results and who can see them and enter them. And so we're still working on that. Don't give up on me yet. And we can talk to Ken. It might just be that we have to ask that they do a secondary submitter for hepatitis C as well. So I'm noting that too. Okay. Anything else?
I would just like to add, now this is me again from Lexington, I would just like to add, when I go into outreach, I only see enterics, no other patients. I'm not able to see it.
Okay. Oh, it froze up. We'll discuss with outreach, or not with outreach, with the lab. Okay. So, moving on, let's see. So what is reportable in Kentucky for hepatitis? So I put the link to the LRC website. I know Dr. Brawley mentioned that Zika is now reportable. That won't show up on this website immediately, but it should show up soon. But I like to give the link out because you can go out and see what the reg actually looks like. If you would like some light reading in the future, it's there for you. I had a little fun to it. Let me see. So I get my sections confused. So in Section 7, starting in 2015 when the reg was approved, we added a couple of conditions like perinatal hepatitis C, kiddos born to hepatitis C infected moms. So that's all in Section 7. You can go through and see that, and I don't want to focus on that. I want to focus on Section 8 because that's what's coming in October. So in Section 8, there is a requirement for electronic laboratory reporting that's going to start. So labs will have to start reporting hepatitis C test results regardless of whether or not they're positive or negative. I know this can be a little concerning for the local health departments because that could potentially be a lot of labs, and I think that's expected. But we want to make sure you understand that the regulation has not changed. We're not reporting chronic hepatitis. We're still only reporting acute hepatitis C. So keep that in mind. Not all of the, obviously your negative lab results are not going to require an investigation in NEDS, and not all of your positive ones will always require an investigation in NEDS. So what is likely to occur is that you're going to be marking these labs as reviewed, and that's the end of your local health department responsibility. KDPH is going to work through how we're going to use the data, so keep an open ear for that. But don't get too concerned with what will be coming in October. So does anybody have any questions about that?
Katie, It's Karen. I just want to clarify that I understand. Starting October 1, we're going to put in all the negatives too. And then just mark them as reviewed, and that way we will have that history on that patient.
Yeah, electronically, yeah. You all don't have to put those in. This is an electronic laboratory requirement. So the laboratories need to report electronically their negative test results. It's not required that you put those in manually, correct?
But unless we're the provider, unless we draw the test, and the state lab is going to do, or they're going to send out any positive Hep C's that we draw. So
for your hepatitis C screening program, is this what you're talking about? Okay.
Right,
This
the
would
local
be-
health department.
DLR should apply to outreach too,
Yeah.
so I need to get on the state.
Yeah. So DLS is a part of, is required to electronically report as well. So it shouldn't require that the local health department do that. They should be reporting electronically because it is a laboratory surveillance component of the regulation. Does that
Right,
help?
but and at this time, it's my understanding that if they get a positive antibody test at the state lab, they do reference that out to another lab who should be putting it in anyway. They would just the state lab would put in their positive antibody test, correct?
Right. And then the LabCorp Quest or whoever will electronically report that send out.
Okay, that's what I thought. Okay, thank you.
You're welcome.
So will DLS be putting in the negative and the positives?
According to the reg, they're supposed to, yes.
Great, thank you.
You're welcome.
Ask them if they know why we're getting the negatives.
Okay, the question is, do you all know why we're getting the negative?
It would be the test, I'm referring to the test that we send to DLS.
Sure. I think this is a question for the entire group.
For the history, so we have that 12-month history?
I think that's a good reason. I mean, I think it. Do you want to comment, Dr. Raleigh?
We put in the negatives after learning that New York City does this, and it enables them to do what Katie said. You can electronically set up an algorithm and determine who is a conversion, but also you can calculate rates of disease. We only presently have estimates of how profound the epidemic is in Kentucky. Once we start getting the negative test results, then we can actually determine how many patients are tested for Hep C in a calendar year, quarter, whatever the interval, and how many have a new test positive. It will take a while until we actually have about a year go by so that we can know who really tested negative and then later test positive, but we will be able to not only document conversions, but we can look at overall rates. CDC is doing this now for us with Quest. They actually are beginning to publish some of the data from Quest by state for baby boomers and others, but we'll be able to do this ourselves over time.
So those negatives give us the universe, the denominator for all those individuals who have been screened.
Absolutely.
Okay, so
Katie? Oh, sorry. Katie, this is Paula from Estill. I have a question. So in NEDS, are we going to see those negative Hep C's in our documents requiring review? And if, okay, so when we do, what do we do with those? Just mark them as reviewed?
Yeah. Now, from right now, there's an algorithm that is pulling some of those labs back in the background. I think, you all saw that maybe a year ago or something where the burden of hepatitis labs that was coming in was so high that it was causing NEDS not to work very well. So a lot of the hepatitis labs that are coming in now are not even coming into your queue. So, that could still be the case. But if you get a negative lab result, that would be something that in your queue that you would mark as reviewed and move on. You don't have to create an investigation for that one.
Okay, thank you.
You're welcome.
somebody else.
Katie,
Uh-huh.
I did. This is Karen again. So if we have a history of a negative now in NEDS, that's what we're gonna see in the future, but we get a conversion in an antibody, but we still don't have the information to fit it to case definition, as in symptoms and elevated LFTs, et cetera. We're still not gonna, how are we gonna handle those, because we know they're a new infection, but we don't have enough to call them acute yet? How do you want us to handle those?
If you have a negative result within 12 months of a positive result, you don't need signs or symptoms. That's a confirmed case. So you'll have to create an investigation for that one. Does that answer your question?
I guess it does. If they don't, I mean, we know by history that they may not have the symptoms or LFT elevations for a number of years, so I was just wondering how we gonna, if just an antibody alone with a history of a negative makes it then acute, yes, I can see that. And those are the ones that we would have to follow up on.
Yes. Yes.
Okay, I was just trying to clarify that.
Yeah. So a negative, so I pulled, will you switch over for me? Thank you. So here, right here and highlighted, a documented negative hepatitis C antibody followed within 12 months by a positive result of any of these tests is then considered a confirmed acute hepatitis C case. So then you'll have to follow that one. Okay?
So you disregard the signs and symptoms and the LFTs then?
Exactly. So all of this stuff in the clinical criteria is not required if you have that positive test 12 months after a negative test. Okay?
Okay, that's good clarification. Thank you.
Okay, you're welcome. Anybody else have questions? Okay. Let me just double check. I'm finished. Let me give you a couple of updates. And this is my information. Jem Britton, who is the nurse consultant for hepatitis B and C, is out on military leave until the 27th. He'll be back a couple of days, and then he's out on military leave again from July on, I think, for about a year. So if you have questions about these cases, you can email Jim, but make sure you copy Sandy Kelly, or you can copy me too. If you can't get a hold of Sandy or Jim, you can call me too, and we'll get your questions answered. I just don't want to leave you without a contact until the newest edition of the infectious disease contact list comes out. And then as far as ERT credit goes, I haven't sent this presentation for approval yet, but usually there's at least an hour out of these ITVs that's approved for ERT credit, so I will submit that and send that out to everybody as soon as I have approval. Any other questions? Oh, and Julie, for hepatitis B, you can call Julie Miracle. And thank you to the group for helping me. I really appreciate that.
Thank you, Katie. We appreciate your time, Katie, and Dr. Brawley and Julie. There are lots of good questions, so I appreciate your support and information. We're running about a half an hour ahead, so Kenyatta is the next speaker on the agenda, but she is in another meeting and not able to join us until right about the time that she has scheduled at 11:35. So I've asked Silvaram Maratha to come and do his presentation now, so I apologize that we'll be going out of sequence on our agenda, but I wanted to go ahead and get Ram up here and provide your information about e-reports. If you want to share that with the group, Ram.
Yes.
Let's see here, I've closed Katie's presentation out. Now, are you going to use your laptop, Ram? Or
I'm going to use my laptop, but still I would like to have that presentation.
Okay, okay. Let me get you set up here. There you go. Ram is the epidemiologist and data manager with the Kentucky Women's Cancer Screening Program. Many of you all, if not most of you all, do know Ron. He's been with the program for 13, 14 years. And so we've really had a lot of good conversations recently about the utilization of e-reports and how local health departments can use e-reports in their day-to-day operations and review, not only for KWCSP, but for the family planning programs, both from a clinical perspective, but then also from a financial management perspective, and how that all relates to your all's QA review and process for both of those women's health programs. So Ron, thank you for bringing the information about the e-reports. Many of the folks may know about e-reports, but I think this will be a good reminder and an update for those who may not know about e-reports and the functionality and all the information that these reports can provide to you within your local agency. So thank you, Ron.
This one if I want to move forward.
So they're seeing the PowerPoint now.
I want to go forward and click on this one and backward. Okay, so.
What do you want to show?
No, just wanted to kind of be more. Just want to move forward and backward. I'm just testing it. Yes. Okay, so.
Go ahead.
Thank you, Joy. Thank you for this opportunity. I think I thank you all for joining me for the Public Health Nursing ITV update, and thank you for giving me this opportunity to discuss about e-reports and that are available to the local health departments and how we can use these tools to improve the quality assurance process and to provide a better care and for better financial management. What I would do is kind of walk you through all the slides and walk you through all the e-reports that are available to you all, the dates that are available, and how you can use those e-reports. Again, I'm Sivaram Maratha. I go by Ram. I'm an epidemiologist, data manager with the Kentucky Women's Cancer Screening Program, and there's my contact information, my phone number, email address are on the slide, so please feel free to contact me or send me an email if you have any questions. The total of 10 e-reports are available to health departments from the Division of Women's Health. Of 10 e-reports, 9 reports are related to the Kentucky Women's Cancer Screening Program, and 1 report is related to the financial management for the family planning program. You can download all the e-reports from the CDP site. They are available each month. They are available at different times. I will talk to you about in a minute about the timelines. 7 of these 10 reports are related to the quality of care, and 3 reports are related to the financial management process. So if you have any challenges in downloading these reports or getting a difficulty in accessing these reports, please call CDP or myself, and we will be very glad to help you get access to these reports. Again, the goal of this presentation is to share with you the reports that are available to you, how they look like, and how you can use them for the quality assurance purposes. Okay, report dates. There are 10 reports, and 7 reports are available to you on 25th of each month. The PAP logs, NAM logs, 1700 reports. Again, 2646, 2647, they are available on 25th of each month. 2 reports, 2653 and 63, are available to you on 10th or the next business day. And 1 report, which is related to the CPT codes, is available to local health departments on the 2nd or the next business day. They all run at different timelines because the goals and objectives of these reports are different. So my request to you is download these reports, look at them and work on them each month, and make sure these reports are my request is make sure that these reports are complete and the reports are worked on. Okay. Next few slides, what I would do is the next 3 slides, I will give you a snapshot of these reports and how they look on CDP side. Once again, if you have a challenges in accessing these reports, please call me or CDP or local health operations, and we will be able to help you get an access to these reports. So if you look at the current slide, so 323, as a PAP log, and then you look at the next one is 676. It's a MAM log report. Again, it's available online through e-reports, through a CDP site. Next 3 reports are the 1706, 1707, 1709 reports. Again, it's just a snapshot of these reports on the CDP site. The next 5 reports, 2646, 47, 53, 54, the 63 reports. Again, just a snapshot of these reports. All these 10 reports are available each month to local health departments. So I'm going to look at the next e-reports. There's a 323 report, which you all know as a PAP log. I can look at, I think probably can look at like a highlighted portion here on the right-hand side corner. It's a report number 323. This report is a cumulative report, which runs from cumulative for the fiscal year, which runs from July 1st, 2015. And the report looks pretty good, except for one missing data here. You can look at the cross mark here. So it looks like this patient had a PAP test on November 2015, November 2nd, 2015. And she had a PAP test, and now it's this missing date and the results. If you can look at this report, if you find any blank spaces on these reports, my request to you is complete these records. Similarly, again, 676 report on the right side, you'll find the report number. Again, this is a cumulative report, goes back to the fiscal year, beginning of the fiscal year. Again, there's one highlighted section here which is the missing data. All these reports have the patient name and patient ID information details. You can go back, look in the medical record to see the dates, the information that's missing. What I did for the presentation is I've removed all the patient names and patient IDs to protect the confidentiality. So, but in your reports, you will find the patient name and patient IDs that you can look and do the quality assurance process. Okay, the next one is 1709 reports. There are 3 reports related to the ACH 58 form, the 1706, 1707, and 1709 report. If you look at this section, go back, this is the first half of the ACH 58 form, which you are all very much familiar with. Now, if you find any record on the 1709 report, what it means is that the screening data, the breast section or the cervical section, is pending or incomplete. To complete a record on the 1709 report, or to remove a record on 1709 report, the way is to complete the breast cancer or cervical cancer screening section. So that's the only way to clean up your 1709 report. I'm going to show you a sample of the 1709 report. I'm looking at the recent report from a health department. On the right-hand side, you will find the 1709 report here. Again, this particular health department has 9 records pending, again highlighted in a circle, red circle. If you look at the cross marks, which shows the blank spaces, which means there's a missing data for these 9 records. I can pick up one record. Let's look at a record date of 8/31/2015. Looks pretty much everything is good except for MAM result. Here, look at, where is my cursor here? Okay. Look at here, the MAM result is pending. So there's no MAM result information here. That's the reason why this report is showing up on the 1709 report. If you do not have any records open for more than 6 months, if you find a record that's open for 6 months, my request is close those records. For example, If you find the first record, which is 7/23/2015, it's almost a year. If you don't find, if the patient doesn't keep an appointment for mammograms or doesn't keep an appointment for any other services, my request to you is close this record. For example, for mammogram, put it as a mammogram needed but not performed. So that is the way you can close these records for patients who do not keep up, do not show up for the mammogram appointments. Once again, my request is do not keep any records open for more than 6 months. It affects the MDE files, the CDC files, and the quality of data we provide to CDC. In 1706 and 1707 reports, these reports, again, you will recognize this is the second half of the ACH 58 form. If you find any record in the 1706 and 1707 report, it means the diagnostic section, either breast section or the cervical section, is pending or missing, or the data is not entered into the CDP's the DC screen, which we call as a cancer data collection screen. So 1706 and 1707 reports are associated or related with the breast cancer and cervical cancer diagnostic section. And my request is, again, look at these records more carefully. I'm going to show you a sample here. This is the 1706 record, breast cancer diagnostic pending record. You can look at the site report number here. Again, this patient has a total of 6 records pending on the screen, pending on this report. It's a cumulative report, goes back to July 1st, 2015, but usually picks up any records that are earlier than 2015. We find 6 records here on this report that are pending or missing, or maybe the patients are still in the process of getting a diagnostic workup. Not necessarily it's a negative, but patients still may be having a maybe a diagnostic mammogram or ultrasound or maybe biopsies. If you mark diagnostic workup, let me go back to earlier. Okay. On the section C and both breast and section and cervical section, if you mark the diagnostic procedures workup plan as a yes, you will find a record showing up on the 1706 and 1707 report. So it does not necessarily negative. It does not necessarily mean that it's pending, and so it means the patient is still in the process of getting a diagnostic workup. 1706. Again, similarly, 1707 report, this is for cervical cancer diagnostic pending record. The report looks very good. They only have 1 record pending here. I think the patient still may be in the process of getting a follow-up done. The next 2 reports are related to the loss to follow-up and workup refused. One report is related, 2646 is related to the cervical cancer loss to follow-up and workup refused. And 2647 report is related to the breast cancer loss to follow-up or workup refused reports. Well, the common question I get from the health departments is, Ram, I looked at your 2646 report, I find 2 patients. What do I do with those 2 records? Said, no, this record, the data on this record is for your information only. Make sure your data is accurate. There are no data entry errors reported. That's data entry errors. And then if the patient comes back to the health department and find out if there is the barriers for the loss to follow. For example, a couple of weeks back, I received a call from one of the health departments. She was working on this or loss to follow-up reports very frequently. She was very much familiar with the reports. A patient came back to the health department who was earlier reported as a loss to follow-up. She called me around, what do I do with this patient? Now I've been following up on these reports, and the patient came back and reported several months back as a loss to follow. I said, no, that's very good that you kept informed about the patient reported as loss to follow. Now find out of the patient whether she was, what was earlier, was it a follow-up, how long it was. For example, it was 6 months back or 7 months back. Does she need to have a screening mammogram done again or CBE done again, or is it can we follow up with earlier results? So that was very smart of her to keep an idea about the reports on the patients. And I did receive several calls saying, Ram, I've got 6 patients reported or 7 patients reported as a loss to follow-up. What do I do? This is for quality assurance purposes. So why are patients getting lost to follow-up? Why are being reported as workup refused? Is there anything we can do to address those issues? One of the calls we received was, Ram, these patients now have a Medicaid. How do we address those issues? So those kind of questions. So, but if you can look at these reports on a monthly basis to see who have been reported to the program as a loss to follow-up or workup refuse, that will be great. The next 3 reports are related to the financial management process. Report 2653 is KWCSP reimbursement report. And then again, 2663 is a family planning reimbursement report. Okay. One of the questions I get is that we paid a labs $3,000. Now we are looking at your expenditure report, and your expenditure report shows we only received $1,300. So what happened to remaining $1,700? To answer to that question lies in these reports. I would like you to look at this report, share with your financial staff to see if the data is complete, data is consistent, and whether you have reported all the CPT codes in the system. If there are any inconsistencies or incompleteness, please call me and I will work with you to make sure your report is complete and we are making payments. This report will tell us who we paid for and how much the health department has received for those services. This is a KWCSP reimbursement report.
And that's like an EOB.
Thank you, Joe. Yes, that's exactly. I forgot about this. More like EOB report to the health departments for the cancer screening services. Okay. And a similar report is for the family planning reimbursement report for the family planning program. You all know family planning is a fee-for-service, and you'll find this report. This will help you know who have been paid, how much was paid for those services. And then you can find all the variables that you need. These 2 reports, the family planning program reimbursement report and the cancer program reimbursement report, are cumulative reports, in the sense they run from the beginning of the fiscal year till the end of the fiscal year. And when come July 2016, again it starts fresh from July 1st, 2016, and will go all the way up to June 30, 2017 data. Again, this is report number 2663. It's a family planning program reimbursement report. For this county has 36 pages. You can look at this one. I printed the last page so that you can see all the variables as well as the cumulative funds this county health department has received from the family planning program.
Ron, I have a question. On the 2663 report, that's a new report this year that was developed just because, since we have converted from a grant allocation process to a fee-for-service process for family planning services. So this might be a report that our financial folks or partners out in local health departments may not be aware of, but it's a new report that was developed specifically for being able to track back those reimbursements for their family planning services, right?
Yes. Thank you, Joy, because this is a fee-for-service. Now in the 2016, the family planning program is in a fee-for-service model, and this is a brand new report for the health departments. And the request is look at these reports more closely, carefully to see if all the CPT codes are being reported, and if you have been reporting all the CPT codes to the right cost center, right ICD-10 codes, ICD-9 codes are being used, so that you are getting reimbursed for all the services. Again, same thing for 2653 report. If you have any questions, suggestions, or improving the process for these reports, please let us know. The last report is 2654 report. It is a KWCSP duplicate CPT codes report. What this report will do is that it will show all the duplicate CPT codes which might result in duplicate payments to health departments. For example, let's look at the first here, the visit date 10/29/2015. We got 2 visit dates with the same patient ID and patient ID number, and we got 2 CPT codes, GO202 and GO202, which is a digital screening mammogram. Based on this data, it tells me that this patient had 2 mammograms done on the same date. So I know this is an error. So the error here is that probably this patient had a technical component, professional component reported. So instead of the technical or the modifiers are missing on this one, and it appears that this patient has 2 mammograms done on the same day. If you look at this report, make sure you report the modifiers, document the modifiers accurately. That is the way you can correct these 2 CPT codes. Otherwise, this will result in a duplicate payments to health departments. So pretty much most of the CPT codes that I see on this report is related, do have a modifiers, a technical component or a professional component. request is once again, look at all the reports, run them on monthly basis, and if you can make sure they're complete and they are accurate. And if you need any more additional reports that can help you in the process of quality assurance process or financial management process, please let us know. Do you have any questions?
So to reiterate, we're asking local health departments to look at the first 7 reports from the clinical perspective and the QA perspective, to work those reports and to assure that those entries are correct and complete and follow up. The last 3 reports are for financial management. 1 for family planning, 2 reports are for the Kentucky Women's Cancer Screening Program. And so we're asking the financial management folks from our local health departments to work those reports, and especially in the event of the family planning report, the 2663, since this is a new program this year, we have had a couple of local health, as far as reimbursement policies, we have had a few local health departments call us and have questions about whether or not a particular family planning service was reimbursed or not. And we found a couple of hiccups in the reimbursement system, and we want to make sure that local health departments have that opportunity and that information to review those reports and make sure that they're being reimbursed correctly and completely. And we want to assure that as well.
Yes, and if any health department is not receiving these reports, please let us know, so we will be able to identify the reasons if you are not getting these reports on a monthly basis or on a timely basis.
Any questions from the field about the reports, the e-reports?
Joy, this is Dorothy from the Purchase District.
Yes, ma'am.
Do these e-reports like disappear at the end of the fiscal year, or how far back can you access? Do you know?
I think it's up to 18 months. I can still go back and look at 2015. I can still access those reports for up to 2015. But if you are looking for a specific report for 2014 or 2013, for example, the cancer screening program report, I can provide you that information all the way back from 2009. But online, I think they are available only up to 18 months.
Okay. Thank you, Ron.
But if you're looking for a report for prior months, please let me know. I will be able to provide you that report.
Any other questions for Ron? Thank you, Ron.
Thank you.
Okay. Next, I'm going to invite Kenyatta Pinkston to come up. I'm going to get you loaded, your PowerPoint ready to go here, Kenyatta, for you.
Should we just put aside water?
Oh, yeah, there. I'll still be looking for it. Thank you. Look at you there, right there on the top of the list. Kenyatta Pinkston is with the Department for Public Health Preparedness Branch. She is the section supervisor, the new section supervisor, isn't that right, Kenyatta? Yeah. For the Administration and Program Evaluation section. So we're going to switch gears a little bit to the Preparedness Branch. She's going to be talking about the Functional Assessment Service Team. So Kenyatta is in the middle of another meeting, and she graciously agreed to come and speak to the ITV group for in between breaks from the other meeting. So thank you for being with us today, Kenyatta.
Thank you for having me, Joy. As Joy's already said, I am a part of the preparedness branch, and I formerly served as the Functional and Access Needs Coordinator for about the last 3 years, and I recently am now a section supervisor. And so I briefly want to discuss or kind of inform you all about a wonderful resource that we have that's available to locals during emergencies and disasters. That's the Functional Assessment Service Team. And before we actually talk about the Functional Assessment Service Team, I want to more so define functional and access needs. I'm not sure if you all are familiar with this term, but I know that you're familiar with the term special needs, and that's the term that has been used a lot previously. However, now, especially in emergencies and disasters, instead of saying special needs, we're trying to move to functional and access needs.
I'm sorry.
Okay.
That's my fault. I'm sorry, Kenyatta.
We're trying to move to functional and access needs. And whenever someone says special needs, it's more, I guess, people in the past have said they felt like they weren't included or they were isolated, and they felt like maybe they did not have the same rights. So functional and access needs is a term that's more inclusive of us all. And it involves populations whose members may have additional needs before, during, and after an incident in functional areas determined by FEMA. And a lot of times these functional areas are identified by the acronym called CMIST, the C-M-I-S, as you see on the screen. The C stands for communication, and this may include those who have limited English, those who are visually impaired or hearing impaired. The M is for medical care, and this includes those who may be on medication or may have medical conditions such as diabetes. The I stands for independence or maintaining independence, and this includes daily activities of living and other things such as toileting and feeding. The S stands for supervision, which is mainly involving children and the elderly, but also includes those who have mental health issues. And the T is for transportation, and this includes those who do not have transportation to maybe get to a shelter if they had to evacuate their homes, or get to a doctor's appointment, such as a dialysis appointment, due to whatever reason during emergencies and disasters. So I say all that to kind of help you understand that functional and access needs includes us all. So I would like for you to take just a minute to look at this slide, and it has several functional and access needs listed. And if you can just look at this slide and think about your own family, think about your extended family, maybe even your coworkers or others in your social settings, and see how many of these may affect you or anyone in those different groups that you're connected to if there was an emergency or disaster. Okay, usually I allow a little bit more time, but since we're limited with our time, I'm going to move on. So normally I ask people to raise their hand if they have less than 5. And I can tell you that normally very few people have raised their hand. Most of the people in the room raise their hand when I say who has more than 5 on their list. And so that just goes to show we're planning, when we say functional and access needs, this is for people in our own families or people who we see on a day-to-day basis. Okay? So now let's talk about the Functional Assessment Service Team. As I said, this is a resource that is available to locals during emergencies and disasters. So the Functional Assessment Service Teams has the acronym FAST. In preparedness, we use a lot of acronyms. So the FAST concept actually started with the state of California in 2006. They realized if they were to have a disaster such as Katrina, they would not be prepared, especially in regards to their functional and access needs populations. So we've met with California and we've looked over their documents, and we were able to create a FAST that was tailored towards Kentucky instead of California. And so the key concept behind FAST is that people with access and functional needs can be accommodated in general population shelters if given the proper support. And I like to point out the word if is a very small word, but it has a big meaning. So for instance, if someone just needs blood pressure medication, or if someone just needs their asthma inhaler, we wouldn't want them to have to go to a medical needs shelter or a more advanced shelter. We would want them to be able to be there with their families and support them in getting that medication and in order to stay there, like I said, with their families, which is the next bullet as well. FAST allows residents to stay with their family members. So what is the purpose of FAST? I like to summarize it. You all can read the slide, but I like to summarize into assess, evaluate, and facilitate. So the FAST team, they will come in the general population shelter and they will assess the functional and access needs residents in the shelter. Once they assess the residents, they will evaluate their needs to see if they can be supported in a general population shelter. If they are able to be supported in the shelter, they will help facilitate those resources into the shelter. If they're unable to be supported, just say for instance they have a more advanced level of care, then they would make that recommendation to the shelter manager that they need to go to an advanced level of care. So our FAST members have experience and knowledge in the following areas: hearing and vision loss, chronic health conditions, physical disabilities, cognitive and developmental disabilities, mental disabilities, aging, and substance abuse. And so our FAST members are basically serving as a link between the shelter residents and the shelter staff. I'm not sure if you all have actually worked in a shelter before, but it's very busy and there's a lot of demands, and just stopping to see, you know, what one person needs may be a challenge depending on the size of that shelter. So FAST members often have credible connections and trust with people. They have an expertise in obtaining resources, and they also have an expertise in delivering services. And so we've partnered with the Department for Aging and Independent Living to provide us with their staff to be our FAST team. And the reason why we wanted to partner with DALE, which is the acronym for them, is because they have staff who are already out there doing the work. They work with the elderly. They have the 15 area agencies on aging and independent living, as well as some other community partners that they partner with. And they're providing resources on a day-to-day basis, whether it's food, medication, whatever it may be. They have those case management skills as well. So we're just asking them to do that same, to do the same work just in a shelter setting during emergencies and disasters, because most likely their clients are going to be the ones that show up in the shelters. So once we decided to partner with DALE, we had to develop a training. And so our training right now is a one-day training. Our participants, like I said, include DALE, and they've provided us with their staff that cover all 120 counties in Kentucky. Our trainers represent a variety of disciplines. Our first training was in spring of 2013, and we approximately trained over 139 members to be a part of our FAST team. So some of the topics that we covered is the ESF-8, which stands for Emergency Support Function 8 overview, and that's the role that the Kentucky Department for Public Health Preparedness Branch has in any emergency or disaster. We talked about functional and access needs and basically explained and gave an overview of what that is. Shelter operations, the American Red Cross was one of our partners who helped us develop this training, and they came to talk about their shelter operations. And then we went into what exactly is FAST and what are the roles and responsibilities, what does it mean to have a resource request, how do we make preparations and response, recovery, and then we ended the training with a practical application and a tabletop exercise. So as of now, the team consists of the following. One FAST coordinator. So, well, let me back up. If we were to have a major disaster or some type of emergency where the FAST was requested, most of the time our State Health Operations Center would be activated. And in our State Health Operations Center, we would have our partners there. And since we partner with Dale, Dale would have representatives in the State Health Operations Center. And if the FAST team was needed, Dale would contact a FAST coordinator. And that's basically someone who takes the lead in the region to contact the FAST members and to give them the information they need, such as where they need to deploy to, what the situation is, or situation awareness. And once the coordinator is identified, they designate a FAST team leader. They pull together a team and they designate a person to act as the leader. The leader basically is going to make sure that all the forms are completed and make sure that they've had that contact with the shelter manager. Of course, if the incident is very large, then we're going to need more than one FAST leader and multiple FAST members. So some common questions about the FAST. How is the FAST requested? Well, the FAST is requested just like any other request during an emergency or disaster. Like I said, the State Health Operations Center may be activated, and so they would send a request to our State Health Operations Center. Most of the time, when that request comes through, like I said, it'll come through our SHOC, State Health Operations Center. If it's not activated, then we have designated people who will be able to receive an email, receive a phone call, just to let us know that the FAST is needed. The second question, can the FAST only be requested when a public health emergency has been declared? And so FAST, they perform their duties or their responsibilities in a shelter setting. So whenever a shelter is open, then the FAST can be requested. So for instance, if there is flooding in a particular county and they need to open a shelter, then that is perfectly fine. If the shelter needs help in identifying functional access needs in their shelter, then they can call on the FAST team. If they already have identified their functional access needs residents, then they can just say, we need a FAST team to come and help us facilitate resources into the shelter. And then who notifies the shelter and the local health department, Department of Operations Center, or local emergency operations center that a team has been dispatched and when they should be expected? So the local doc or EOC should make the request and logistics. They would make the request and the logistics team would notify them when the request has been filled, when they should expect to see our FAST members arrive to the shelters. And in our contract with the Department of Age and Independent Living, whenever the request has been made, once we've had that initial contact with them, then they will arrive no later than 2 hours after the request has gone through.
That was my question, Kenyatta. Are our partners with Independent Aging Living, are they actually located within 120 counties, or are they assigned, a multiple county area? Or
They are located in all counties. Okay. However, some counties are stronger than others. Okay. So we noticed that in some areas of the state, they don't have as many that have been trained, but we're able to pull from other counties so they can come and assist as well.
Okay, so the local health departments may know their Dale partners within their community?
They may know them, however, which is one of the reasons why I'm here to inform you all about this wonderful resource, is that we've realized that a lot of people do not know yet. Yeah. And so we want to get the word out that this resource is available and that, all you have to do if you have a shelter open in your area and you need assistance with FAN populations, functional access needs, then a request can be made. Actually, the request would work like any other request. So if someone needed, you know, I don't know, water bottles because they're unable to use their water, that request for FAST would be just like the request for water. Okay, so what are the next steps regarding FAST? So right now, we've done all the trainings, but we haven't necessarily had a request for FAST to come to any shelter yet. So we've been doing this since 2013, and nobody has really requested the fasting. So we can't tell you what areas we need to improve in just yet, or, you know, we just aren't able to kind of make that determination just yet. So what we're doing is providing engagement trainings, and that's to keep our FAST members up to date on functional access needs, the new updates that come out regarding functional access needs. We also provide the Kentucky Outreach Information Network and the Kentucky Functional Needs Collaborative ITV workshop yearly. I know some of you have probably heard about that. And so normally we have it around October. This year, I believe it's going to be in November. I'm not sure of that exact date, but information will be sent to you all. And so there's various workshops that will discuss things associated with functional access needs and emergencies and disasters. And we also plan to have our FAST teams participate in local exercises. So we would like for them, if the health departments are having exercises, feel free to call on the FAST. We have contact information that we can give you for your FAST members. Department of Aging and Independent Living has a massive list of the FAST members, so we can provide you with the FAST members in your area. And then we plan on partnering with other state departments, and we would like to basically expand beyond Department of Aging and Independent Living. So before I close, I just want to remind you that FAST, although it's a wonderful resource, it does not relieve anyone from being personally prepared by at least identifying an out-of-state and out-of-area contact, developing an emergency kit, and developing an evacuation plan if sheltering is needed. And even though we say that we're providing this service to functional access needs residents in a shelter setting, I always take the opportunity to let everyone know that we all need to be prepared for emergencies and disasters. We all need to have an out-of-area and out-of-state contact, an emergency kit, and an evacuation plan for our families. So at this time, do you all have any questions for me?
I was just going to ask, is there a listing out there with the county contacts for FAST, and I just need to contact you and see who their person is?
There's not a listing that's available, but yes, you would contact me, and I would contact Dale, and I can send you the list for your county. Any more questions? All right, if you have any questions, you can feel free to contact Joy, or you can look me up in the Global. And right now we don't have a functional access needs coordinator, so I'm still kind of serving in both roles. And Heather Walls, I don't know, she's our MRC coordinator. She's assisting me as well. So thank you all.
Thank you, Kenyatta. Nice job. Okay. Next, I'll invite Becky Kissicake to come on up. About 20 attachments for today's presentation. Let's see. Is it this one? Mm-hmm. Huh? No. You see it?
Yeah. And it's okay.
No, no.
It's not a big deal.
Be right with you, folks. Let's see. Okay. It would have been in a Word document, right, or PDF?
I'm thinking of a PDF.
Yeah. Okay. Do you see it?
I don't.
Okay.
No big deal.
Okay.
No
Sorry.
big deal. No.
All right. So they have received that information. I sent it out yesterday.
That's perfect.
Okay. I'd like to introduce Becky Kissick-Hake next, who is the branch manager of the Education Workforce Development Branch here within the Department for Public Health. And that actually falls under the Division of Administration and Financial Management. Becky and I and her team have had the pleasure to work hand in glove over the last year regarding nursing CEs and the approval of nursing CEs. And so she's just a valuable resource for the Department for Public Health in regards to education and workforce development, and has been a great resource for me personally and professionally going through the CE approval process. So she has some updates to share with you all about EWD, and so I wanted to invite her to come today and provide those updates for you all. Are you going to mention about the train registration piece? Okay, good. I just wanted to make sure. All righty. Thank you.
Ma'am. And thank you all for joining us today and for having me. I appreciate the opportunity to speak with you very briefly. Many of you, of course, are familiar with the Educational Workforce Development Branch, as many of you have registered on train this morning for this ITV. But we wanted to take just a second to let you know that, first of all, of course, the Educational Workforce Development Branch is committed to providing ongoing education opportunities for you all. And what we know is that one of the biggest areas for us is that nursing continuing education piece. And so, as many of you, and as Joy just alluded to, for about a year now, we've had some changes to the Department CE program. And so we wanted to provide you with some additional information on that program. We've received a lot of questions about what is a CE, what qualifies, what doesn't qualify, how does the process work, and what do I need? In the attachments that Joy forwarded you all yesterday, you would have received sort of what we refer to as a quick reference. That quick reference document is based, of course, on the KBN providership and those administrative regulations. It kind of outlines for you all what qualifies, what doesn't qualify, as well as list out some important kind of tips, what we would need, as well as our contact information. In addition to that, I wanted to take a moment to share with you all that last year we had 387 courses approved on train. 270 of those were CE, nursing CE courses. So we know that nursing CE is about 70% of what we do, and that makes you all, of course, a very valuable resource for us. EWD is going through a process of continued quality assurance and quality improvement. And we're getting ready to roll out a new needs assessment strategy. And that's really why I'd asked Joy if I could join you all today. We're going to approach this needs assessment a little bit differently than we have done in the past. And I say that because we're really interested in hearing from you all about what works, what doesn't work, and what are those things that you need. And I'll give you an example. We heard from a district health department that they didn't know how, or they didn't have a course provider on site. They hadn't been provided training in some time, and they didn't understand how that ITV registration piece worked. And so many of you may have noticed we've changed the way in which you registered for today's session. The reason we did that is because we heard from those local health departments out there that if your course provider is on vacation, or maybe your course provider has left and you've not received training, you're not sure how to register your site, and in turn you're not registering for an ITV. So those are the things that we really want to hear about. We also heard from folks out there that, the evaluation piece, the certificate piece is a little bit confusing. How do I set that up in train? How do I access? How do I get that? So over the course of about the last year, we've actually been doing a lot of that. Folks have submitted courses to us, and we take care of that piece. Let us help you in those regards. In addition to that, if there are things that you come across that you're not sure about, you don't know how to kind of navigate, we're always here to be a resource. And that's really what we want to stress for folks, is that we're here to help. So please don't ever hesitate to call us, ask us those questions. And in addition to that, we're going to be reaching out to initially each of our course providers at the local health departments to have conversations with them about what works, what doesn't work, and what you need. But please don't think that that doesn't mean that I don't want to hear from any of you individually on an ongoing basis, because I welcome that opportunity. My contact information, as well as Joy's, as well as Tony Leeser in my Educational Workforce Development branch, is on the back of the quick reference guide that was handed out today. And I would invite all of you to use that information. Let me know, give me a phone call, an email, anything at all that from a quality improvement standpoint you'd like to see or you'd like changed, I'd like to hear about. Do y'all have any questions for me? All right.
I have one.
Yes,
Would
ma'am.
It's not a question, it's a comment. Would you, or a request, would you mind to share with the group the different way that we're recording our ITVs now, and that so we'll be able to have a expedited archive webcast available and a quicker turnaround time. Would you mind just to mention that to the audience?
Not a problem. So, many of you have expressed some concern as well over the video conference sessions and kind of the quality, whether that be audio or visual. And as many of you also are aware, we've run into some technical challenges there over the course of the last year. And so we actually have Joe McDaniel today present with us videotaping. That allows us to pull that video a little bit faster. It allows us a little bit cleaner audio. And it's something that we actually have the course shell ready and trained for the archived webcast. As soon as Joa has rendered out the video, we'll be good to go. And we'll have that turned around much faster for you. So it's something that we know has been an issue in the past. And we're hoping that the new strategy will continue to decrease that time, that turnaround time for you all. You're welcome.
One other request, would you mind to touch base just in general? I'm getting ready to provide some updates from the lab. Would you mind to share with them that you've had a meeting this week with DLS about the shipping and the packaging and shipping training?
Yep. So the lab specifically, we met with them earlier this week to discuss some of that packaging training pieces. And one of the things that they would like to do is a video tutorial piece, 5 to 10 minute video over there in the lab to kind of demonstrate that category B packaging, as well as some centrifuge tutorials. We're going to be looking at doing that within the next week or so, and hopefully rolling that out very quickly for you all as well. Any other questions? All right. Well, thank you all for your time.
Thank you, Becky. Okay. Y'all are going to get to see how quick I am on my feet today. I asked the lab, they wanted me to read a few updates for them, and they sent me a PowerPoint presentation this morning, so which is an excellent PowerPoint presentation. I just didn't know I was going to get a PowerPoint presentation. So we'll see how this goes. It does have valuable information, though. Wanted to share this with you all, and for those of you all who will be participating through an archived webcast, you'll have this information to reference at a later time. So Robin Cotton and Leanne Bates developed this PowerPoint, and so if you have any questions, I'll ask you to refer to them. Their contact information is at the end of this PowerPoint. Several of you all, we have heard that there have been delivery issues, time frame issues as far as mailing your all specimens. We have mentioned in at least one previous ITV about the opportunity for local health departments to use the Division of Laboratory Services FedEx number, and the samples there that could be used that could be sent via this FedEx number are listed there on the slide. If you do not have the DLS FedEx number and want to use that number, it is at a discounted rate. They were able to obtain that rate from, quantity discount perspective. Leanne Bates will be glad to set you up with an account with FedEx to print your labels if you so choose to use FedEx to send your samples. So I wanted to bring that information to your attention. Hopefully that will help mitigate or minimize the time frames for getting some of these samples to the lab, because we have heard that that was a problem. The next slide is about the packaging and shipping training. We have received several questions about that training, and that's why I had asked Becky to mention the meeting that she had early this week with Robin and Leanne. There are a few current resources available as far as packaging and shipping. There's the train module entitled What the Laboratorian Should Know. And so there's the course ID for that train module. That is a broad, provide the fundamentals for laboratory services, checklists, and provides checklists for your site-specific training records. And then, as Becky mentioned, a video is being developed. It's my understanding that the laboratory, DLS, is responsible and has provided trainings for local health departments who need a packaging and shipping training. I believe it's every 2 years. So they are working on that to assist you all meet that time frame and that requirement. Any questions about the packaging and shipping training? That's on its way.
So will we need to do this first course, the 106-2513, and the one that is in process?
Let me see here, Amy, just a second. That might be a Robin question. It says the training record from the module will be used as the basis of your training with an additional checklist. I'll have to ask her that. I'm not for sure. I'll get clarification on that for you, okay? It looks like the train module that's already existing is like a 101 type of training, and then the packaging and shipping training is in addition to that. And it's but let me clarify that just to make sure, and I'll send that out from or have Robin send it out. Okay. Good question.
Thank you.
Yep. Okay. And then the last point, three points on this presentation: the FedEx number, the packaging and shipping training, and then the Clearview HIV assay Clearview has been purchased by Kenvio. And so what she has done, and thank you, shout out to Sophie French for bringing that to DLS's attention. Robin has gone through all of the paperwork and the QA checklists, and switched out the title Clearview for Kenvio SureCheck, so those references will be correct now. She also sent the announcement letter and a revised quality assurance checklist that reflects the Kenvio name, which will replace Clearview. So let me see here. So this is the letter for y'all's records, just to let you all know that this has happened. There's their website. They have a quick reference guide. Everything is still the same. When Robin called me this morning, all of the procedures, the processes, everything about performing the test, she said, are exactly the same. It's just the name change. She asked that you all retire. I like that terminology. Retire all of the Clearview documents and go ahead and start using the Kenvio as you start receiving those new products. And I wasn't for sure. Have you all started receiving the test with Kimbio, from Kimbio? Or have you all noticed yet? Maybe not. So as you start receiving the HIV test with Kimbio, go ahead and switch your materials out, please. And the QC log she mentioned. So here is Robin Cotton and Leanne Bates' contact information. So just in summary, the FedEx rates, if you'd like to use that and piggyback on the DLS contract, please contact Leanne Bates for that. Robin and Leanne are working on the packaging and shipping training to be available ASAP. And then the Clearview HIV assay tests are being replaced, they were bought out by Kimbio, excuse me. Any questions on the lab updates? Okay. The next ITV will be August 18th. So we already have 3 presentations, I think, on the agenda for August 18th. So it'll be another full agenda. Thank you all so much for all that you do every day. I know it's a busy time out there for everyone. Let us know if you need anything, and we appreciate all that you do.
Joy.
Have a great, yes.
Could we ask a quick question since we have a couple minutes?
Sure, absolutely.
Just, we heard from the CADA meeting that the electronic health record was delayed some, but we didn't have any details, and I'm just curious if we have a new timeline or you know anything that can update us.
Yeah. Is that Northern Kentucky?
Yes.
Is that Lisa?
Thanks.
Yeah, okay.
Yes.
I thought that was you, Lisa. I do know that the delay has been from the initial rollout. I believe that date was August 1st. I believe it will be a couple of months later, perhaps January or February, but that's will be discussed at the CADA meeting on Tuesday. But just to let you know that Oates and the cabinet folks and DPH are working closely and full speed ahead with ECW and our partners. We continue to meet. I still have three to four meetings a week with ECW as far as building and making sure that we're ready to go for that go live. There have been a couple of delays, and I apologize for that, but they're going to be talking about that revised rollout timeframe at CADA on Tuesday, and so we'll be sure to make sure I'll be at that CADA meeting, so I'll be sure to provide that information to the nurse leaders after that meeting, okay?
All right,
Yep.
thanks.
All right, thanks for hanging in there and your interest, and we're getting there. We've had a couple of hiccups in the time frame, but we're still forging ahead. Any other questions that I may know the answer to, or I can get the answer for you? Okay. The CCSG is on track to be published for July 1st. I will share with you all, you'll notice something on the forms and patient education material heading. We're going to add QA tools onto that heading, and the NEC is working on compiling QA tool samples that local health department nurse leaders can use. We'll go ahead and post the women's health tools. You all already have, I think most of you all already have those for cancer and family planning, cancer screening, breast and cervical, and family planning. But as we get those kind of dusted off and reviewed and approved by the program folks, we have heard that I've heard this request from numerous local health department nurse leaders that they wanted to be able to have access and have those tools available to them as you all perform your own internal or peer-reviewed QA process. So we wanted to provide those tools for you. We thought if we included those as a part of the CCSG that would allow kind of provide that opportunity for an annual review by the program folks if anything needed to be changed on those. So they'd be a part of that document for your all's review and information. So just kind of to let you know that we're going to be, we kind of have set a placeholder as far as for the QA tools, and we'll be building upon that and adding those tools for you all, for your resource. Anything else? Okay. All right. Thanks again for everybody, and glad you could join us. See you August 18th. Bye-bye.